Dr. Anesh Rugnath to discuss the topic low back pain and leg pain. This is the second session where we're going to discuss the anatomy and pathophysiology of low back and leg pain. Our session objectives today is to discuss the relevant lower back and leg anatomy, talk about the common anatomical pathology of the lumbar spine that presents as low back pain, talk about the potential differential diagnosis that produces acute or chronic low back pain and leg pain, and then we're going to go on and discuss pain confined just to the lower extremity. Starting off, we will talk about the relevant anatomy of the lower back. The lumbosacral spinal cord terminates in the conus medullaris at the level of the body of the L1 vertebrae, i.e. the ending of the cord itself. And after that you get the strands that form the conus medullaris. This contains motor and sensory nerve roots that forms the cauda equina. These then unite at the dorsal root ganglion to form individual spinal nerves. These spinal nerves are all anastomose in the lumbosacral plexus and run down to form the major nerves supplying the leg. If you look at the picture on the right side, you can see the spine is divided into the cervical vertebrae, the thoracic vertebrae, the lumbar vertebrae, and below that are the sacrum and ends in the coccyx. The picture on the left shows an AP view of the spine. You can see the sacrum or the tailbone to where the pelvic bones attach that supports the lumbar vertebrae above it. The sacrum meets the lumbar vertebrae at the L5 vertebral body. You can see in between the vertebrae there is the intervertebral discs. There's different parts to each vertebrae. You can see the spinous processes. There's 5 of them depicted in this picture that runs down the middle. On each side you have projections known as transverse processes. If you take the L5 vertebrae itself, you'll see from the transverse process there's projections that project upward, and this is the superior articular process. The projections that project downwards is the inferior articular process, and this superior and inferior articular process meet to form a joint known as the facet joint. On the right side we see fluoroscopic pictures that we need to learn to identify the different landmarks on these pictures, so that when it comes to interventional pain management we know where to place the needle when performing injections. So the lumbar spine anatomy itself, we will concentrate on the lumbar area because this is the cause of most of the pain for back pain. There are 5 vertebrae in the lumbar region that's labeled from L1 to L5, and they are made up of the body that's anteriorly separated by intervertebral discs. The laminar, pedicles and bony processes are in the posterior part of the spine. These processes and vertebral arches create a hollow spinal canal which houses the spinal cord, which terminates in the cauda equina and spinal nerves. The bony processes also consist of the spinous process, the transverse process, the superior and inferior articular processes, as discussed, that forms the facet joint. The spinal nerves exit between the vertebral bodies via the neural foramen to supply the lower extremity. Intervertebral discs are made up of an outer hard covering called the annulus fibrosus and an inner gel-like center known as the nucleus pulposus. If you look at the picture on the top left, you can see the purple hard outer covering of the vertebral disc, that's the annulus fibrosus, and you can see the blue gel-like center, that's the nucleus pulposus, and this together makes up the intervertebral disc. You can see to the left of that purple intervertebral disc there's a yellow nerve exiting a foramen that constitutes a nerve root. The spinal cord is visible running down the center of the canal. The picture at the bottom further illustrates the anatomy. There is the pointer to the intervertebral disc. Above and below that intervertebral disc you can see the body of the vertebrae. The spinal cord is visible going through a column through the center, and again you can see a spinal nerve exiting from the foramen. Projecting backwards you can see the spinous processes. Projecting forward you can see the transverse processes. Projecting up from the transverse process you will see the superior articular process. Projecting below is the inferior articular process. Continuing with lumbar spine anatomy, the vertebrae are linked by joint capsules, ligaments, tendons and muscles, and these have extensive nerve innervations. The lumbar spine is governed by 4 functional groups of muscles, and these are split into extensors, flexors, lateral flexors and rotators. Ligaments also play an important role in spine stability and prevent injury from hyperflexion and hyperextension. The 3 main ligaments, as seen in the picture on the right above, you see the anterior longitudinal ligament right in front. Behind that is the vertebral body. Behind that is the posterior longitudinal ligament, and at the back of the spinal canal you can see the ligamentum flavum. The ligamentum flavum is an important landmark to remember as we do a few procedures targeting this area, especially a common procedure like an epidural steroid injection. The picture below you can see the extensive muscle groups that hold this spine together and gives it its stability. In this slide we'll talk about the potential differential diagnoses that can possibly cause low back pain. This purple slide on the left, we mentioned earlier something about mechanical backache. The first 2 columns are diagnoses that where pain arises from the spinal column itself, and the referred pain is where there's no pathology in the spinal column but pain is presented to the back from other areas. So the mechanical backache is the primary pathology of the back, where we normally see musculocutaneous injury or lumbosacral pain as being the most common etiology, right? Spondylosis, or also known as degenerative arthritis of the spine. We can get issues with the intervertebral disc like herniation. There's anatomic abnormalities like scoliosis and spondylolisthesis, where the spine doesn't stay in alignment. Spinal stenosis is another big cause for low back pain, and then there's compression fractures. The second column here shows where there's no bony pathology per per se, but systemic diseases that manifest as back pain, something like infection in the lumbar spinal column where you have an epidural abscess, or the body of the spine of the vertebrae becomes infected with osteomyelitis. The disc can become inflamed, giving you discitis. Commonly in people with cancer or certain cancers, you get metastasis to the vertebrae, commonly seen in lung, breast, prostate, renal, and other cancers. You also get leptomeningeal carcinoma. Leptomeninges is the coverings of the spinal cord, and this is also seen from metastasis from the lung, breast, melanoma, lymphoma, and leukemia. Inflammatory back pain is pretty common. Is a diagnosis seen in axial spondyloarthritis, that's ankylosing spondylitis, also in psoriatic arthritis, reactive arthritis. You can get back pain. The other cause of back pain is pain from intra-abdominal pathology that can be referred to the back. And most of these are something that requires immediate medical attention because they can be an emergent situation. Things like aortic dissection and aneurysms that are expanding can refer pain to the back. Pancreatitis is a very common cause for referral of pain to the lower back. Kidney infections, abscesses around the kidney, kidney stones can present with back pain. The blue slide on the left side, these are more common pathologies seen with the lower extremity. Lumbar radiculopathy is where problems arise with pathology in the lower back that causes pain to radiate down either lower extremity. So they normally present with low back pain, can present with motor weakness. Peripheral artery disease gives you an achy, burny pain in the legs. Myalgia paresthetica is a burning anterolateral thigh pain that's caused by irritation of the lateral femoral cutaneous nerve as it exits over the pelvis. Greater trochanteric bursitis gives you lateral hip pain. Arthritis in the hip, arthritis in the knee can give you pain in the lower extremity. Sacroiliac joint pain is very common diagnosis for low back pain. Piriformis muscle spasm gives you diffuse buttock and posterior thigh pain. Avascular necrosis of the hip also causes hip pain that comes from long-term steroid use. And then there's neuropathies of the lower extremity caused by either compression or inflammatory / metabolic issues like we would see in diabetes, history of rheumatoid arthritis. Again, this is another slide depicting the same thing, and this time showing you what mechanical back pain is, what is non-mechanical back pain, but still the pathology is within the spinal column. And the third part of that is the visceral disease, which makes up about 2% of back pain, where you got disease of the pelvic organs, renal disease, and GI disease. Again, in the mechanical low back pain, which is 97% of back pain, the commonest things are lumbar strain, problems with the facet joints, disc pathology, spinal stenosis, compression fractures, scoliosis, kyphosis, which is malalignment of the spine that creates pressure on different parts of the spine, producing pain. So let's start off with the first differential diagnosis for low back pain, and that's degenerative disc disease. herniated disc. Disc degeneration is estimated to be the source of at least 39% of low back pain cases, so the majority of them is seen here. Herniated discs are a result of a defect in the outer covering, that's the annulus, as we discussed before, that allows the nucleus pulposus, which is a centered gel-like structure, to herniate through the defect. When this defect herniates laterally and compresses the exiting nerve root that comes out of the neural foramen, this causes both back and associated leg pain. This diagnosis is common in people in their 30s and 40s, although the older age group are with increased risk. This can occur because of injury, improper lifting, or even can occur spontaneously in diseased discs. Risk factors include genetics, age, smoking, and certain occupations. The nucleus pulposus, which is the inner soft gel-like substance, is made up of approximately 80% water and also contains type 2 collagen and proteoglycans. These are responsible for retaining water within the disc. With age, there is reduction in this proteoglycans, leading to disc dehydration and desiccation, and therefore eventually causing the disc to collapse, resulting in defects or tears in the annulus with consequent herniation of the nucleus pulposus. Smoking hastens the drying up or desiccation of the disc. The picture on the right side again shows you the intervertebral disc between the bodies of the vertebrae. You can see there's a defect laterally on the blown up picture in the purple annulus, and that allows some of the gel-like disc material to herniate laterally and impinge on the nerve root exiting there from the foramen, causing irritation and pain. In this picture we see different defects in the annulus. The picture on the top right is a normal looking disc with a hard fibrous intact outer layer with a soft gel inside. Picture B shows you where the disc is just bulging. There's a mild defect in your annulus with some of the material filling into that defect. In C, we got a bigger defect where actually quite a bit of gel material herniates through that defect and causes compression of the exiting nerve root. In D, we have an actual tear in the annulus, and disc in the inner gel-like material is extruded through that defect and causes quite a significant compression of the exiting nerve root, can also cause spinal stenosis. The next diagnosis for low back pain affects mainly which is spinal stenosis, which affects mainly late, middle-aged, and older adults. The cause is multifactorial, with disc disease, bony hypertrophy, and thickening of the ligamentum flavum being the most important. The symptoms are caused by direct pressure on the cauda equina, the spinal cord, and also on the exiting nerve roots. There is also compression of the vascular supply of the nerve roots that present as pain. Normally this is exacerbated by extension of the lumbar spine in conditions when you stand and lying down in the prone position. If you look at the picture on the right side, the big gray area again, that's the intervertebral disc. You can see the annulus fibrosis again with the gel-like center, and you can see it herniating it to cause pressure on the exiting nerve root and also encroaching on the spinal canal, compressing the spinal cord. That's from below up. From above, projecting down, we got the ligamentum flavum, and this can hypertrophy and cause narrowing of the canal, pressing the spinal cord and the nerve roots. The canal is made up of bone, so if you get bony spurs or hypertrophy of the bone, again it compromises the spinal canal and causes compression of the spinal cord and cauda equina. The third major cause of low back pain, where we see 30% of cases of low back pain, is from facet joint pain, where we got pathology in the facet joint itself. This is a component of mechanical back pain caused by long-term degenerative changes due to repetitive activity, excessive weight, abnormal posture and arthritic conditions, scoliosis and retrorasthesis, which is the stepping forward or stepping back of the spinal alignment that causes extra pressure on the facet joints, resulting in pain. Acute back trauma can also produce active facet joint inflammation due to stretching of the capsule and damage to the ligament that, the damage to the capsule that forms the facet joint. This is an encapsulated joint with synovial fluid in it. The pictures below shows you the vertebral body, the projections behind. You can see right at the back is the spinal process. The one projecting above is the superior articular again, the one presenting downwards with the arrow facing down is the inferior articular process, and those two meet to form the facet joint. With forward bending, you can see the facet joint opens up, and with bending backwards or extension, it closes the facet joint and causes pressure on the joint itself. So hence, if there is pathology in the facet joint and you extend, it reproduces the back pain. The picture on the top right again shows you the facet joints. The nerve in red is a branch that we call the medial branch that supplies the facet joint. It's purely a sensory nerve that carries pain sensations away from the facet joint into the spinal cord and up to the brain. The picture below again is a oblique depiction of the spine, with picture B being a fluoroscopic image. In that fluoroscopic image, you can see the superior articular process, the transverse process, the inferior articular process, and the lucency in between those two is the facet joint. Sacroiliac joint is another major cause of about 15% of low back pain. The sacroiliac joint is formed by the meeting of the sacrum and the ilium, as depicted in the picture on the top right. These joints are designed to take heavy loads of force, allowing us to walk, run, jump, bend, etc., absorbing the impact and playing a critical role in transferring the weight of the upper body to the lower body. Inflammation of this sacroiliac joint, known as sacroiliitis, is responsible again for about 15% of low back pain, and the causes of sacroiliitis includes traumatic injury, where you get a sudden impact, such as would occur in a motor vehicle accident or fall, arthritic conditions like osteoarthritis due to wear and tear, and also inflammatory arthritis. Sacroiliitis is also seen in pregnancy because the SI joint, which is sacroiliac joint, must loosen and stretch to accommodate childbirth. Added weight and altered gait during pregnancy leads to additional stresses and abdominal wear on the SI joint, leading to pain. Infection is a rare cause of sacroiliac joint pain, with the main causes being age, wear and tear, especially in people who engage in excessive activity like runners and joggers. This slide shows again the anatomy of the lumbosacral spine. You can see the sacrum and coccyx below. We attached to the sacrum and coccyx is the vertebrae. You can see the labeling of L5 that sits above the sacrum. Above that's the L4 and the L3. The tags are on the vertebral bodies. In between you can see the intervertebral disc. The bodies are attached via a pedicle to the processes in the back. Facing towards us is the process again, the transverse process facing posteriorly. The finger-like projections, those are the spinous processes. You can see the SI joints where the L4 and L5 meet. The middle picture shows the bony connections between the body and the projections behind, and sometimes that bony connection doesn't form, leading to instability of the spine, and we get a condition known as spondylolisthesis, which we'll discuss coming up, right? And this again is fluoroscopic pictures of the spine. You can see the picture A with the label L5. The arrows there is showing you the defect where the bony or the bones haven't fused, leaving a defect in the pars interarticularis, which leads to the picture on the far right. You can see the L5 is not stable and has moved forward over the sacrum, so the anterior alignment of the spine is distorted, and this is what we call anterior or anterolisthesis. Obviously, when the spine alignment gets offset like that, the spinal canal is compromised, and also there's excessive pressure placed on the facet joints, leading to pain. Picture B outlines something that, again, that we call the Scotty dog, where you can see facing forward is the transverse process that we call the nose of the Scotty dog. Projecting up is the ears of the Scotty dog, which is the superior articular process. The arrow showing something facing down is the inferior articular process, and you can see the pedicle depicted as the eye of the Scotty dog. Another cause for back pain is vertebral compression fractures, and this is defined as a condition where the vertebral body has decreased in height by at least 15 to 20% due to fracture. This is more commonly seen in the thoracic spine, caused by severe osteoporosis. Even simple daily tasks, sneezing forcefully or lifting a light object, can cause this type of fracture. When you have moderate osteoporosis, it obviously requires greater force, such as trauma, falling from a height, or lifting very heavy objects to cause a vertebral compression fracture. Metastatic tumors to the spine weakens the bone and causes vertebral fractures, and should be considered as a cause in patients under the age of 55 years old who has had minimal trauma and a vertebral fracture has been identified. People with normal spines can also suffer a vertebral body fracture through severe trauma, such as a car accident, a sports injury, or a very hard fall. Vertebral compression fractures affects about 750,000 people annually. Moving on to some anatomy of the leg itself, with pain generators or the differential diagnosis of things that cause pain to go down the leg. If we look at the picture in the middle depicting the lower back and the leg itself, you can see a thick yellow nerve running all the way from the buttock into the foot. That's the sciatic nerve. picture on the far right again shows the labeling of the lumbar spine. The picture on the left side with the different colored areas that radiate from the back down the leg. When you get pain in these particular distributions, taking the L4 nerve root, you can see that in purple. You can see the distribution of it, where it starts off in the lower back, goes on the lateral thigh, comes over the anterior knee and into the foot. The L5 initially starts off in the lower back, comes more on the posterolateral part of the thigh, to the back of the knee, down the lateral part of the calf. The S1 nerve root starts in the lower back, comes over the buttock, posterior knee, and the posterolateral aspect of the calf into the lateral aspect of the foot. This is important when you're taking history for the patient. If they give you this typical distribution, it helps you to identify which nerve root is involved in the pathology. So let's talk quickly about some acute and chronic differential diagnoses that cause low back pain. Bilateral lesions, meaning if you find pathology on both sides with symptoms maybe running down both legs, it normally shows that the problem starts up in the spinal canal, affecting the roots and the cauda equina. When you got loss of bladder control or bowel control, this indicates that the lesion is probably in the cauda equina, and less common, it could be a sacral plexopathy. There are, as we know, non-neurological causes of low back pain, particularly with kidney stones, aortic aneurysms, ischemia of the lower extremity, and other intra-abdominal pathological processes. The thing about multiple lesions, it can make differential diagnosis more difficult, and pinpointing a specific pain generator becomes a more difficult task. For example, radiculopathy, there are two or three different levels. That is, if there is nerve root compression, maybe at L2, L3, L4, L5, it is more difficult to pinpoint the cause. Pain confined only to the lower back, that generally doesn't radiate down to the lower extremities, is generally caused by a pathology in the lower back itself. Pain confined to the leg generally is a leg disorder like knee pain, hip pain. Although neuropathic pain from the lumbar spine disease can radiate down the leg without back pain, but this occurs in a minority of patients. Pain in both the lower back and the leg usually is caused by lumbar radiculopathy. That is the pathology in the back that is compressing, either exiting spinal nerve roots. Clinical abnormalities confined to just one nerve root distribution usually is caused by intervertebral disc disease. Clinical abnormalities that involve several nerve distributions usually are caused by plexus lesions.